So welcome to IPOPI Hard Talks. My name is Martine Pergent. I am the president of IPOPI, and this is my pleasure to co-moderate this digital event with Dr. Nizar Malawi. Hello, Nizar.
Hello, Martine. Hello, Keith. I'm Dr. Malawi. I'm the chairman of the IPOPI Medical Advisory Panel, and I'm very glad to co-moderate this event with you.
First, let me take a moment to thank our sponsor, Sumitomo, for making this event possible. Before we start, I will take a moment to briefly explain the IPOPI Hard Talks concept for those who have not yet attended these webinars. With IPOPI Hard Talks, we will explore the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. The theme today is diagnosis and management of pediatric congenital athymia. To engage in this discussion, I am delighted to welcome our challenger today, Professor Andrew Gennery from the United Kingdom. And Professor Gennery, you are a professor in pediatric immunology and hematopoietic stem cell transplantation at the University of Newcastle upon Tyne and honorary consultant for the Northern Supra-Regional Bone Marrow Transplant Unit for SCID and related disorders at the Great North Children's Hospital, Newcastle upon Tyne.
Thank you.
And our presenter today is Dr. Keith Sacco from Malta. It's a pleasure to have you, Keith. You're a clinical immunologist based in Malta, and you also worked for a long time in London and in the US. You are interested in mechanistic approaches to medicine, including machine learning and expanding access to medical care for patients with immune-mediated diseases.
Thanks for having me.
So welcome to both of you. How will this work? So Dr. Sacco, you will give your lecture to begin with, and after the lecture, Professor Gennery will share his comments, and together you will discuss and debate this topic. During the presentation and the discussion between our two guests, you will be able to send a written question in the question tab. So let's begin, and Dr. Sacco, the floor is yours.
Thank you, Ms. Pergent and Dr. Malawi. It is once again truly a pleasure to be speaking to this global audience today. We'll be talking about a disorder, congenital athymia, which is by definition an ultra-rare condition. What does ultra-rare mean? It means that this is a disorder that is present in less than 1 in 50,000 prevalence. In fact, to give an example, in the United States, congenital athymia is found in around 20 babies born in a population of greater than 300 million. That's 20 per year. And what's going on? This is an issue with one of the primary immune organs, the thymus. We classically look at the thymus as being, let's say, an elementary school of the immune system, whereby the immune system learns to fight off infection. And the way I classically describe this to my patients is that our bone marrow, as seen in this diagram here, our bone marrow is producing very diverse repertoire of T cells. And these T cells are like the generals of the immune system, that they orchestrate the immune response. Each T cell is very unique in that it recognizes protein sequences called epitopes between 9 to 11 amino acids, let's say, and they're very specific. Let's say we do have T cells already that can recognize any viruses that are going to come in the future that we have not yet met. And this repertoire is so diverse and unique in that there are some, we have more diverse T cells, each a unique diverse T cells, than there are grains of sand on this earth. But these T cells need to be educated. And what happens is they leave the bone marrow, they go up to the thymus, which sits in the anterior mediastinum in front of the heart, pretty active in the first few years of life, where two processes occur. The first is positive selection, whereby those T cells learn to bind to that protein signature called the epitope. And they also undergo a process called negative selection, because by this great process of VDJ recombination, there will be T cells that will inevitably recognize self. And by doing so, those T cells that bind strongly to self need to either be eliminated or converted to cells we call T regulatory cells, because that poses a risk of autoimmunity. That was a bit of a high-level overview, given that we have a very diverse audience today. And so what are we facing if we have congenital athymia, meaning that we have an absent thymus in utero during the fetal stages of life? We have an infant that is born with absent naive T cells, and this can be detected on flow cytometry. Before that, in countries that have newborn screening with PCR-based T cell restriction excision circles, they may have low or absent cells. And because of that, this condition may be mistaken for severe combined immune deficiency, because they both present with low T cells. Now, as you probably are well aware, there are various forms of severe combined immune deficiency. We classically denote them by their B cell and NK cell numbers. Let's say T minus, B minus, NK plus SCID is a form of that. And congenital athymia does mimic T minus, B plus, NK plus SCID, in that typically B cell and NK cells can be present. We will discuss how we can differentiate between SCID and congenital athymia, because it does have significant management implications. Genetic testing is one of the ways by which we can ascertain the diagnosis, because some gene variants, as we will discover, are significant etiologies for athymia. When we do break down the main causes for this presentation of congenital athymia, the top two I'm highlighting in orange: syndromes and others in blue. The top two conditions are genetic conditions. The first one, 22q11.2 deletion due to the absence of the TBX1 gene, is more commonly known as DiGeorge syndrome. Now, DiGeorge syndrome has a number of patients that present with what is known as partial DiGeorge syndrome, in that they have sufficient T cells that develop over time, and patients have enough T cells to fight off infections. Sometimes we have patients who have borderline T cells, and we monitor them through life. We may temporarily avoid live vaccines, in some cases provide antimicrobial prophylaxis, but in the vast majority, they do have some T cells. There is a small proportion that is born with congenital athymia, and this is the group of patients we're talking about today, in that they typically have absent naive T cells. The second category, up to 25% of congenital athymia, is CHARGE syndrome, another syndromic condition. But the third leading cause is diabetic embryopathy, which is an acquired issue, meaning that with significant diabetes in the mom, this can present with athymia in the fetus. Then are, of course, other conditions. Specifically, there can be no gene identified or as yet described. Issues such as ectodermal dysplasia can present this way, and other genes would include FOXN1, TBX2, and PAX1 genes. So here we are. Let's say we have a patient that has been diagnosed with congenital athymia. Typically, we have a neonate, given that at least we're referring to, in many countries, that diagnosis can be achieved pretty quickly, finding a very low absolute lymphocyte count and reflexing to naive T cell flow panel. Of course, the management is very similar to severe combined immune deficiency, in that isolation is imperative. Typically, this is reverse isolation with laminar flow. Hand washing protocols, we do recommend stopping breastfeeding and checking CMV virus status in the mom. In many cases, the moms are encouraged to continue expressing breast milk until this is ascertained. And when patients are not hospitalized, strict at-home isolation and hygiene is strongly recommended and ideally reinforced. How about prophylaxis? Because this is a T cell issue, we recommend broad antimicrobial prophylaxis, and that includes antivirals such as valacyclovir. After the first 28 days, cotrimoxazole with trimethoprim. Antifungals such as fluconazole, particularly in areas that are endemic for certain fungi. And where there is a bit of a difference from severe combined immune deficiency is that azithromycin is typically added in this condition for anti-mycobacterial prophylaxis. There is, of course, a very close monitoring in that if there's any sign of infection, prompt treatment is initiated soon after cultures are obtained. Typically, live vaccines are avoided, and the reason being is because we don't have T cells, and as you are aware in this group, certain live vaccines, for example, rubella, in conditions such as severe combined immune deficiency or combined immune deficiencies, can lead to significant complications. And then there is secondary form of treatment that includes immunoglobulin replacement. Many patients were receiving immunoglobulin replacement, starting at a dose of around 0.5 grams per kilogram and up titrated as needed, particularly in the setting that the mom will not be breastfeeding and the neonate will have only received IgD through placental transfer. Blood products need to be seronegative for CMV and irradiated. And there's also a condition that may occur. We did talk about both positive and negative selection, that in this scenario, T cells may become autoreactive and cause a form of graft versus host disease. This is, in a way, I don't want to commit any crime saying that it is similar to OMEN, but it's similar in a standpoint of oligoclonality and that the cells are autoreactive. And they can proliferate and cause a form of what we call autologous graft versus host disease, whereby immunomodulation with medications such as tacrolimus or cyclosporin are needed. This typically involves a multidisciplinary approach. And more so because the top two causes that we talked about, Chart syndrome and DiGeorge syndrome, are syndromes, there are other systems that need to be addressed. And this involves specifically calcium monitoring and supplementation, also cholecalciferol, vitamin D supplementation. Typically, endocrinology is involved here, specifically with DiGeorge syndrome. These patients also may have tracheal and heart defects, and surgical repair is needed, sometimes macroglossia, tracheostomies, lines, monitoring, and feeding tubes. So pretty complex patient care requiring multidisciplinary management. So how do we know if it's athymia or severe combined immune deficiency? And as you are very well aware, we do know that with severe combined immune deficiency, early allogeneic transplantation is recommended because it has survival implications. It does improve survival because the more infections we avoid going into transplant from severe combined deficiency, the better. So we need to come to a decision because with SCID, we need to go down a pathway of early allogeneic bone marrow transplantation. With athymia, there's other forms of definitive management. And in some cases whereby patients receive the bone marrow transplant in congenital athymia, they had worse outcomes because of that. So we can get a FISH to look for 22q11.2 deletion. This is pretty rapid. Within a few days, we get an answer. And then, targeted genetic testing is pretty rapid in the United States. Typically, within a few days, we could send a rapid exome, trio exome, sometimes both parents and the patient, versus a genetic panel that looks for SCID. Typically, this would include TBX1 and deletions for Chart syndrome. Of course, flow cytometry is important. This can be obtained pretty rapidly as well. Looking at T cells, B cells, NK cells, it's important to have some markers for naive and memory cells. It could be our CD45RA for naive and CD45RO. Of course, these panels vary across the world, but it's very important to have markers for naive T cells because that does allow us to make the diagnosis of congenital athymia. Now, if a few days go by and we are still stuck, as to sometimes genetic testing does come back negative. I've had a patient like that where it looked like T minus, B plus, NK plus kit, but genetic testing came back negative, we can consider what is known an artificial thymic organoid. And this is a test whereby it is performed in a research setting that can help us decide, identify if T cells can go all the way to maturation. So how does this occur? An ATTO is like having an ex vivo, or more like an in vitro thymus. So it's looking at the T cells from the patient. We get the patient's blood, generate induced pluripotent stem cells. This is from Marita Bosticardo's and Francesca Pala's work in Gigi Notrangelo's lab at the NIH. And for further details of the protocol, I would refer the audience to review this paper. But what's happening is we have the pluripotent stem cells under certain growth factors and cytokines. They would differentiate, and we would check surface markers along the way. And in certain forms of SCID, such as reticular dysgenesis, there is a block. The T cells cannot mature down to the CD4 and CD8 T cell stage, and they block in the pre-T1 stage. In conditions such as RAG1, RAG2 that affect VDJ recombination, the cells block in the double positive stage. But if we provide this structure, the artificial thymic organoid, in a patient with congenital athymia, their T cells do manage to differentiate all the way to ZT4 T cells. So that tells us from the clinical side that if we provide a thymus for this patient, then hypothetically they can then reconstitute their T cells. So we've established that our patient has congenital athymia. They're getting supportive treatment, but what is the definitive treatment? This is a condition whereby, similar to SCID, without a transplant, a thymus transplant, it would be fatal. And based upon the work from Mary Louise Markert at Duke and a lot of work also in London that has taken place since then, there is this procedure that happens both in the US and the UK called thymus transplantation or implantation. What happens is there is a significant amount of patients, these are pediatric patients, that have congenital heart disease, not due to other syndromes maybe, or congenital heart disease that is pretty common in infancy, and because of that, some thymic tissue has to be resected to access the heart and the great vessels. Now, some residual thymic tissue is left. It is not a case of the thymic tissue being extra thymic tissue being taken away for the transplantation. It is usually a tissue that is discarded, but this tissue, instead of being discarded, is then used for a transplantation, and it comes from a donor. Typically, one of the laws of transplantation here is not really followed, so to speak, because it's not a strict HLA matching. And the thymic tissue is then sliced. There's a protocol and how it is cultured, make sure it is good quality and there's no infection, there's no colonization. That thymic tissue, if it passes a few processes, quite a bit of rigorous processes of manipulation, then it can then be transplanted in the quadriceps muscle. In the United States, this procedure that used to occur and still does occur at Duke University Medical Center received approval by the Food and Drug Administration. And the product itself is called Rethymic. Now, the FDA has designated this as a thymic implant, not a transplant, because it is tissue that is manipulated in a lab outside the body. And it's still very regulated. And so the label has come out that the process in the US has to take place up to this day in June of 2024 at Duke University Medical Center. There are some efforts into having this label expanded using data showing viable tissue from other sites across the country. In the UK, a similar process has been approved by the Human Tissue Authority of the United Kingdom for thymus transplantation, and it's also approved to be performed in one hospital, which is a specialty, you can say, quaternary hospital for sick children, the Great Ormond Street Hospital in London, and the same process of surgery applies. So what happens prior to going for thymus transplant? Pretty much we are strictly observing a lot of the procedures that have taken place with immediate early control. We do counsel the family to avoid public places and daycare, limiting contact with young children with strict hand washing. Of course, this does have significant psycho-social implications, especially because time does pass. It's, as you can imagine, it is not easy obtaining a thymus transplant versus a bone marrow transplant. And we strictly enforce preventing breastfeeding, especially in the case of CMV positivity. There is a risk of cryptosporidium infection through ingested water. So in patients who ingest water from the tap, we strongly recommend bottled water and boiling water. We avoid live vaccines due to the reasons mentioned, and we maintain leukodepleted irradiated blood products and CMV negativity, all the while trying to optimize the other organ functions, specifically with CHARD syndrome and DiGeorge syndrome. There are other end organs that are affected, as we mentioned, the parathyroids, calcium issues, as well as cardiothoracic issues. So let's go over the pathway broadly in the United States, which I've been privy to. Have had 2 patients go through this pathway previously. In the US, newborn screening has now been universal across all 50 states for a few years. So you can say almost 100%, if not all patients, are picked up by a positive newborn screen. They usually have low TREX or inconclusive report, and then we find low naive T cells. Once the diagnosis of SCID versus congenital athymia is identified, they're usually referred to a tertiary pediatric hospital, either within state. If it's a smaller state, they go to the closest state or are managed via telemedicine. The immediate recommendations are implemented, and then they're referred for rethymic implantation. This process involves 2 applications. The first will be a patient enrollment form, and that gets the patient also through what's known as a pre-approval process, and also a formal referral to Duke University Medical Center on the bone marrow transplantation team there. Now, in the US, the healthcare system is a privatized healthcare system, and so there's an insurance process that is required to approve 2 pathways. First, having to approve the rethymic, that by the FDA label can only occur up to this day at Duke University Medical Center in North Carolina, as well as the approval for the actual clinical care that happens at Duke. And so this is probably the while where the patients are waiting and getting optimized, continuing the long-term management until they get the thymic implant. When the time comes, specifically when tissue is available at the right dose for the patient's body surface area and the approvals are in place, the patient then is transferred over to Duke University Medical Center where they get the implant. They get some immediate care, looking to at the early post-op care, making sure that the patient is stabilized, and after that there is continuous management via telecare with the tertiary center where they are back home for long-term management. How does that differ from the United Kingdom? I'd like to thank Professor Gennery and Dr. Buckland in the UK who clarified more of the nuance in the United Kingdom. Of course, there are various places in Europe and some trials in the United Kingdom of newborn screening. So the majority, my understanding, is that most patients still are diagnosed with congenital athymia through newborn screening, but some others are diagnosed a bit later because there's also international referrals. In London, also classically, London has a lot of international connections historically and very well connected by flight. There's very similar immediate management and prophylaxis prior to transfer. But the process then occurs at Great Ormond Street, and it is an HTA-approved thymus transplant. And this occurs on a clinical protocol within the United Kingdom's National Health Service. The patient is once again stabilized and transferred, or either locally if they're a UK patient, or overseas if they're international. Now, when do naive T cells appear? And they typically come about, the earliest is around 3 months, but we're looking more close to the 5-month period in those who reconstitute a bit later. In the patients whereby we can deem them quote unquote safe from infection is once we start to see immune reconstitution, meaning that we have sufficient naive T cells and antimicrobial prophylaxis can start to be withdrawn. That is a bit of a complex process, looking at serial monitoring of T cells and also lymphocyte stimulation, PHA simulation, among others, and making sure there isn't AGVHD pre and post transplant. Typically, reconstitution is happening within 6 to 12 months. Now, the survival rate is now closer to 75% if transplant recipients. Once those naive T cells show up, a lot of the antimicrobial prophylaxis and immunoglobulin replacement can be lifted. And a significant predictor of mortality is the viral infectious status going into transplant, specifically CMV. There have been other patients who are going into transplant who've had SARS-CoV-2 colonization, also norovirus, adenovirus. The SARS-CoV-2 story, I guess, is being characterized if that has any prognostic implications going forward. And the significant mortality I wanted to highlight really occurs in the first year. Once the first year is out, most significantly, the mortality does stabilize. And so if the patients go past that 1-year window of follow-up and they get reconstitution, they're really outside the red zone, so to speak. Thank you for your time. And with that, I'm happy to take any questions.
So, Professor Gennery, do you have any comments?
Yeah.
Of course.
So first of all, thank you very much. That was a very exhaustive and very interesting talk. Of course, I have comments and questions for you. You say, and some of these are contentious, but I think that's one of the beauties of this platform, actually, that we can raise some controversies. So you say earlier in your talk that congenital athymia can be mistaken for SCID. I have a real problem with it. I know it's classically not considered to be SCID, but I really fail to understand why that should be in many respects, because these patients who are born with no T cells, who can be picked up on newborn screening for SCID, and who present clinically, certainly from an immunological perspective, in exactly the same way. And I would really, and this isn't something specifically with your talk, but I think within the community, we haven't tended to consider these to be SCID patients, but I don't really see why not. I know that they can have other issues, but actually, so can some of the other if you like, classic SCID problems. So we know AK2 deficiency can have a central neural deafness. ADA SCID can have a number of other issues associated not specifically with the immune system. And I really do wonder whether we need to think about reclassifying these athymic disorders as part of the SCID spectrum. And in fact, with Miriam van der Berg and Carsten Beckman and some other colleagues, we've just written a review article for Jackie on newborn screening, and actually argue this point that for the athymic patients that are completely athymic with complete absence of T cells, really this is a form of SCID. I don't know if you have a comment on that.
I totally concur. The point you were.
Dr. Sacco, would you mind to just give the main points, because the sound was so difficult for the audience?
Sure. My understanding, what Professor Gennery was raising, is that congenital athymia should be considered to be reclassified as a subset of SCID, given that it is so similar in presentation and immunophenotype and also clinical phenotype. And I concur. I think even within the general domain of pediatric care, mentioning the word SCID on a pediatric intensive care unit does elicit a form of, okay, social isolation, okay, we need to be much more careful, rather than say athymia. I think that that's partly from a language standpoint, but it's also, I think, the aggressiveness of needing to monitor and treat these patients going into thymic implant. If I may ask, actually, because it's also been a question of mine going into this, I'm aware verbally of some patients who've received bone marrow transplantation and found to actually have needed a thymus instead of a new bone marrow. I'm not a transplanter by specialization, and so I do wonder, if you could elaborate and highlight why is it such an important issue to identify a priori that we should need a thymus versus a bone marrow transplant from the get-go?
Yeah, thank you for that question. I mean, as a transplanter, I think that hematopoietic stem cell transplant is fairly straightforward, and broadly these days has a fairly low risk, particularly in well patients. But certainly in Europe, we would give chemotherapy prior to doing the transplant. And if that's not a necessary part of treatment in order to cure the patient, you should try and avoid that. So there are risks associated with stem cell transplant. Not always patients survive. And if you do it and the patient survives and it's a technically successful procedure, but the patient has not benefited from it, then actually you shouldn't have done that. I don't know if that makes sense. How common are these diseases? Do you think they will become more common as we get more widespread newborn screening?
Yeah, no, how common are these conditions? And I also see some comments if participants from Africa as well, which is very interesting, right? I think since the advent of newborn screening, my understanding is that we're picking up more of these patients, and even the United States, we used to talk about 17 patients, then up over 20, but there's quite a few patients now awaiting to get thymic implantation. I also think it's interesting to note in regards to, I'm not a geneticist, but speaking with geneticists in regards to chromosomal issues, deletions, and having, if there's data pertaining to environmental factors, they do tend that certain deletions are getting a bit more prevalent, and certain parts around underserved populations related to either possible. This is theory. I'm not going off of any data, just to be clear. But there's some theory about increased VOCs, volatile organic compounds, etc., and increased deletions. But I think it's probably due to increased screening in the Western world, specifically in countries with newborn screening, that we're picking this up even further.
Sure, I agree with you. I think we will find these patients are more common than we believe. I have another point, and that's to do with the isolation of these patients once a diagnosis has been made. This is really difficult, even in classic SCID, and I think we don't know how to do this well. You mentioned laminar flow isolation, but of course I think that's impractical. When these patients are picked up for the athymic patients, you've often got several months before you get the procedure. And I think hospitals don't have space simply to isolate patients for that long before treatment. We know in the US series of newborn screened kids that there are a number of patients that got infection whilst awaiting transplant. And again, I wondered if you had any other further observations. If you have a solution, let me know, because I think we'd like to know.
That I think, the comment you're raising about isolation is very important, because speaking from the a personal experience of managing 2 patients with congenital athymia, I think that was the most pragmatic issue, right? A patient needs a chest X-ray, suddenly, the whole isolation precautions are not observed, or the patient needs to go down for a procedure, something fell through the cracks. And it's also an issue of having the infrastructure, right? And what we had in the US, I am aware that a lot of patients who also live far out are eventually discharged as they are awaiting thymic implantation. And we do our best to connect with them remotely once they are stabilized, having home health nursing go in. But it's definitely far from perfect. What the parents have shared with us is that sometimes it is easier for them to control their own environment within their own home, rather than having staff go in. This is not a condemnation of hospital care. It's just a reality, as you were saying, of shift work and rooms being changed and acute care needs that occur in the hospital.
Mm-hmm. In the chat,
yeah, I agree.
Go ahead, Professor Gennery.
No, go on.
No, I will
go on, Martine. What was your question?
Yeah, we have in the chat some questions, and the first one is coming from India. What is so special about thymic transplantation? Why is it performed in only few centers like Gosh or Duke Medical Center, US? And why not in other centers who perform HSCT for kids, for example? Can you answer?
So I have a comment about that at the end, so we will come back to that. I've got 1 or 2 comments and questions before then. I think the field of artificial thymic organoid development is really interesting, scientifically and also, of course, diagnostically. Could you explain a little bit about how the diagnosis can be made using that organoid?
Yep, right. No, I think I concur with you, because this arose from a personal experience of mine. We had a patient who looked like SCID, and we thought it was SCID. Fish came back negative, genetics came back negative. Our center did bone marrow transplantation in the US, and so we're ready to go ahead and transplant. But then the calcium looked pretty stable, and this ended up being a patient with Chart syndrome. But the first genetic run came back negative. And so the ATTO did help us identify that. And so what it does entail, I've seen it also. I've seen the process itself, thanks to Marita Bosticardova. I can thank her here, because it's very laborious as a process, specifically in that you have to go in and once you induce pluripotent stem cells, you have to go change media and flow and look at various steps. It does take a few weeks to get a response, to get the full workup done. But the nice thing about it is that it's very helpful even for severe combined immune deficiency, I would say, because you can identify if the patient has a block in T cell development, even in the absence of a genetic defect. And so that it can help you. If a patient is, so quote unquote, blocked in the double positive T cell stage, and we still don't have a genetic defect, and maybe there's an intronic variant that we're not having yet described, or a gene modifier, then it's pretty safe to say you can go for an allogeneic bone marrow transplant, versus if there's complete development with this type of scenario, then the answer is really a thymus issue.
No, go ahead.
What I've learned, it does take quite a bit of coordination and getting fresh blood shipped out, and especially, it's. I do know in Europe it happens as well. I'm privy to labs that do it in Europe too now, and in the US and Canada there are 2 labs that do this. but I also understand globally it is an issue, right? I mean, not having a place where you can ship fresh blood to a continent within a few hours is an issue to perform this test.
Yeah, I agree. I'm going to come on to access shortly, but I have another two questions, really. The first is, you talked about results and how good they are. Could you maybe mention something about autoimmunity after the procedure? How common is that, and is it associated with any part of the procedure, do you think?
Yes. So the short answer is yes. What I have seen and from the data is I've had one case of let's say the autologous GVHD, not from an autoimmune standpoint. That patient was on cyclosporin. In the reconstitution period, autoimmunity can be a feature, and it is a quite complex facet to manage, because the choice of immunomodulation in relation to still wanting reconstitution, but also managing the autoimmunity is not an easy one. And of course, as autoimmunity and inflammation data at the time of any transplant is considered to have more of a poor prognostic outcome, it is not something that is enjoyed to have during that process.
Sure. And certainly I think data from London suggests that HLA matching may be implicated in autoimmunity. So I know that they have been able to freeze thymic tissue, and if they've been able to have at least some HLA matching, there is at least a suggestion within their data that if there is some HLA matching, autoimmunity is less prevalent. But I think it's not absolute. So I think, I mean, again, I have two more points, but the burning issue clearly here, I think, are two related issues. One is access. How do we get more patients to this treatment? And then the other is affordability, because I don't know what the cost is in the United States, for instance, but it's clearly not a cheap treatment, and it's how we are able to get patients around the world to access this treatment in a way that they can afford it. Now, there was a question about why cannot every transplant center do this, and I think, I mean, it's a fair comment, but this is actually always going to be a very rare treatment. I think in my, let's say, plus 20 years of working in the field, I've only ever come across 4 or 5 patients that would have needed a thymic transplant. And I think it is not helpful for a single center to be able to do this procedure once every 2 or 3 or 4 years, because they do not become expert at it. And therefore, I think there is a huge difference in concentrating the expertise into a relatively few centers that do it. But I do wonder if 2 centers in the world is maybe too few. And I wonder if you have any thoughts on that.
I personally do concur. I feel privileged in that I've spoken to folks on both sides, in the UK and the US, and seeing how that process compares. And it's, as you say, I think it's difficult. There are issues on both sides of the pond, so to speak, right? On the one hand, in the US, access really, I do believe that the bottleneck of access comes down to the payer side of things. It is a very laborious process as well, and so there are 2 factors that come into the payment. It is not just it's the rethymic per se, the product, but also the actual care that goes into it. And let's not forget, as you're mentioning, it's not only the immune issue. I mean, it's also managing the calciums that are fluctuating in these patients. It's also managing the tracheostomies, managing the heart issues. These patients need to sometimes go up to the intensive care unit. So there's a lot of cost and hospitalization effort, as well as the transport, the med evacuation that goes into that care. Also, the payers in the US, most of the patients come from to talk about also underserved. A lot of these patients can be on what's called the Medicaid program, whereby the states is the main insurer, and there are negotiated rates for certain procedures, etc. And because this is ultra rare, sometimes states may have never heard of this, and the payer, and so there's a lot of need on the physician side locally to write letters, vouch with medical directors for the need of the program. The other issue is that the older the infant gets, the lower the chance statistically is to get a thymus, because as certain time goes by, the body surface area increases, the dose of thymus needed is larger, and of course you need to find a thymus that is large enough for that patient. And so there does appear to be a window, not just from a viral standpoint, but also from a thymus dose. What I do know in the US, this is the rethymic process has now been the technology transfer is now owned by one company, right? And so it happens in the private sector. What I understand in the UK is, there's a lot of work that happens at the level of physicians who are really dedicated, and staff who go in, and slice up thymic tissue on the holidays, and I think if we can mention a name, I think Professor Graham Davies, who has been a pioneer also in the UK, who's put a lot of personal work on that. In that, it kind of cuts both ways, right? I think there are issues on both sides, and logistics are not easy. Now to answer, I think somebody raised also a question, if I may, regarding rethymic and why it happens in one place in the US. Well, the FDA label itself only allows for, because the data submitted to the FDA was the whole protocol that occurred at Duke University Medical Center, the FDA approved the data, the licensing for that process to occur only within the buildings in North Carolina, Duke University Medical Center, and the building where the thymus process occurs. And of course, the US is, from East Coast to West Coast can be a 6-hour flight, right? Which is, Malta to Sweden is 4 hours, right? So just to show how far certain sites are. But as you say, I think there are a lot of underserved areas: Africa, Asia, South America, Oceania, and maybe that's another discussion to be had, which specific centers in different parts of the world that are equipped to do that and can handle the multidisciplinary side of things.
Yeah, no, I completely agree with you, Keith. And I think, my own feeling is in Europe, we probably need at least 2 centers. In the North America, we need at least 2 or maybe 3. We probably need at least 1 in South America, probably 2. In Asia, I have no idea, probably at least 2 or 3. Oceania, probably 1. Africa, there are many things we need to sort out in Africa before we get to the stage of thymic transplant, but they will certainly need several centers. And while I never see thymic transplant being performed in as many centers as stem cell transplant, maybe it's a little bit more like gene therapy, where that is happening in a few specialized centers, and it may be that patients go to a center for treatment and then go back to their equally specialized center not doing thymic transplant for the recovery, and that's perhaps a possible model for the future. My one final point, I think, if I may, Martine, I don't know if we have time.
Yeah, sure. Please.
So my one final point is, for patients who will not get a thymic transplant for whatever logistical reason, there is still an alternative option, and that is a stem cell infusion from ideally from a matched donor, and most ideally from a matched sibling. And whilst we know that the results of that are not as good as thymic transplant, and that the stem cell infusion or the marrow infusion has a finite life period of a few years and maybe perhaps needs to be repeated, it is at least an option for patients who will never ever be able to get to thymic transplant, and will at least give them some years of reasonable quality of life and perhaps options for other treatments in the future. So for the many areas in the world where thymic transplant is only a dream, there is an alternative, albeit one that doesn't have such good results, and there is a higher mortality associated with that.
Yeah, this is very good information. Thank you for that. You both touched upon newborn screening and the role it can play in the detection of athymia. And we have a question in the tab about is it possible to diagnose congenital athymia through prenatal imaging? And would it be worth doing that?
Yeah, I think that's really... that's a very interesting question. I think at the moment we probably don't have the technology to do that, actually. I think the ability to be confident in a prenatal diagnosis would be not good enough to be able to be certain that this is thymic rather than a stem cell problem. And then, I mean, the other problem, of course, is very, very rarely, and I know it's certainly been reported in the USA, there are issues where you can have a stem cell defect and athymia. And there are at least, I think, 2 case reports of patients with Artemis SCID, which is one of our classical SCID diagnoses, but also when they had a successful transplant that didn't work, were found to have DiGeorge syndrome also and needed to go on and have a thymic transplant. Now, clearly, you are an incredibly unlucky individual to have 2 defects like that, but it does happen. And I suspect that, you know, trying to sort that out postnatally is very difficult. Trying to sort these problems out prenatally, I think, would be very hard.
Okay, thank you for the answer. Is there any other thing we would like to add? No?
I had one other sort of...
Sure.
I have one other kind of blue sky comment, because we've talked really here about congenital athymia.
Yeah.
But there are 1 or 2 other situations, and in my own field particularly, it would be somebody who had had a successful stem cell transplant, but maybe got very severe graft versus host disease, which destroyed the thymus. And I don't know that people have done this yet, considered thymic transplant post-stem cell transplant in the face of severe GVHD. But I think as thymic transplant becomes a more regular, more common procedure, we may be able to expand the indications for which we use it to patients who've got maybe secondary thymic failure.
Very interesting. Thank you for the blue sky comment. And so I think that we come to the end of this Hard Talks. And I want to thank you both of you for discussing diagnosis and management of pediatric congenital athymia with us today. To Professor Gennery for being such a good challenger, because the sound improved at the end, fortunately. And to Dr. Sacco for your very interesting talk and for all the answers you have provided both. So we will now also share a short feedback form that should pop up on your screen, and it's very useful for us to understand your feedback and to hear from your comments to continue to improve the concept. Thanks again to all of you for attending this new edition of IPOPI Hard Talks. In a few days, you will be able to watch it on the IPOPI YouTube channel. Don't hesitate to share it as much as you can. And many thanks to all of the attendants. And I could see India, I could see Uganda, Colombia, the US, UK, Estonia, and many more. So thank you for being with us. And thank you, of course, to Sumitomo for making it possible. And see you to the next IPOPI Hard Talks. It will be on the 11th of July. And this will be a discussion about advanced in X-linked agammaglobulinemia with expert professors, Professor Isabel Mates from Leiden University, Belgium, and Professor Pamela Lee from Hong Kong University. So see you there, and thank you.
Thank you. Thank you, Keith.
Thank you.
Thank you, Andy.
Thanks.
Thank you so much.